Welcome, everybody. Look at this. This is incredible. I am so thankful you all are taking time out of your day to join the conversation and listen in to what has very quickly become my personal passion, which is health equity. And we are joined today, and I feel very lucky to be hosting and moderating this town hall during Breast Cancer Action Month. Notice I didn't say awareness, because we are all about action now and putting, walking the walk, not just talking the talk. And I'm really lucky to be surrounded by some very strong women for a great discussion today. What we'll do is I'll ask each of the panelists to introduce themselves. Give your name, a little bit of background about you, and then I'll preface with some data, and then we'll dive into the conversation. For those of you that are on the call today, feel free to pop your questions in the chat. We'll be monitoring them, and we'll do our best to respond to those questions as we move along. Sarah, would you like to begin?
Oh, sure. Hi, everyone. I'm Sarah Chavez. I work at Siteman Cancer Center in St. Louis as part of their community outreach and engagement team. And I'm here in the capacity of being the senior scientist, so I'm sort of the data person on the team, but I'm also part of a BRCA family. And I'm a mother of 6, so I've got a lot of incentive to make sure that the next generation doesn't face the same challenges with breast cancer.
Thank you so much. Hope.
Hi, everyone. I'm Hope Crable. I'm the Executive Director of the Masonic Cancer Alliance, which is the outreach network of KU Cancer Center. And I also have the opportunity to serve as the Missouri Cancer Consortium Chair, which will be ending in January. And we will have Lindsay Haslug as the next chair of the Missouri Cancer Consortium. It's my pleasure to partner on this. I get to work with Sarah and Natty and Crystal and Erica frequently. So this is just a joy to be here today.
Thank you, Hope. Natty. Oh. Oh, let's unmute you, Natty. I'm so sorry. Natty and Crystal, if you could unmute yourselves.
You know, you'd think after doing so many Zooms, I'd remember to unmute myself, but no. So my name is Natabona Mabachi, or Natty, and I'm an assistant professor in the Department of Family Medicine at the University of Kansas Medical Center. I'm in the research division, and I focus on different types of research, but at the center of all of my research is sort of a equity and empowerment and community-based framework that I work off of. And one of the areas that I have been doing work on is cervical cancer screening. I work both locally in Kansas City and globally in Kenya. Good to meet you all.
Thank you so much, Crystal.
Good morning, everyone. I'm Crystal Lumpkins. I'm associate professor in the same department as Natty, Department of Family Medicine and Community Health, the research division, and I am a health communications scholar that does community-based participatory research. So community engagement is a huge core of what I do, addressing health disparities. I'm so excited to just hear about and to be here with all these panelists and on this town hall. So looking forward to this discussion.
Thank you so much. So speakers, I ask you to take yourself off mute, please. Everybody else who is participating, you are on mute, and we're going to keep this conversational. Again, feel free to introduce yourself in the chat, ask a question along the way. We'll do our best to answer those questions, but I have a feeling this will be a very full, only 60-minute discussion. We were chatting prior to this and had already really gotten into some good discussion points. So we framed today's conversation around evidence and the history of health equity with some kind of anecdotal data based on personal and professional experiences as well. So I want to, we'll touch on this and also apply it specifically to our region. But I want to give you a little bit of a background. So the focus on health equity, I think, really began, and again, you all are the experts, but please correct me if I'm wrong, with the U.S. Surgeon General's Healthy People Initiative back in the day, which laid out a plan with data-driven national objectives to improve health in the well-being over that first decade. In 1994, under U.S. Surgeon General David Satcher, the conversation of health equity moved from the reduction of disparities to the elimination of disparities, which is a very bold move. And you would hope the political will would follow that. Unfortunately, it hasn't over the decade. And we are at a moment when we can really have an honest conversation about this. Over the years, there have been lots of discussions and focus on the social determinants of health. As I mentioned, however, unfortunately, not as much progress made as we would hope. So we're going to dive into most of this a little bit later, but as of late, more and more people are now prioritizing health equity because of how COVID has really put a microscope on the inequities faced by racial and ethnic populations. When we dive into the cancer world specifically, we of course already know that exists and have known for a while. Black Americans have had the highest overall cancer death rate of any racial or ethnic group in the US for the past 4 decades. Diving down deeper, Black Americans are 40% more likely to die from breast cancer. In our region alone, we have several counties that have a higher than the national average mortality rate from breast cancer. And I'm hoping our conversation today will uncover some true solutions that as a community we can pull together to achieve equity. And I continue to say we can't possibly achieve our mission at Susan G. Komen, Kansas and Western Missouri to end breast cancer forever without first addressing health equity. So let's dive into the discussion. First question, Sarah, I'm going to put you on the spot, and this will be the same question for each of you. So let's spend some time defining and talking about health equity for our region. So I'd like for each of you to talk about, from your expertise and experience and through your work, what is health equity?
I know for me, health equity has always been sort of a part of our community here at Siteman. I work for part of the program to eliminate cancer disparities. So we are really focused on not only understanding the disparities, but trying to sort of open up the conversation within our community and to try to think of health equity more as sort of being the change, like how you actually get into the community, you identify needs, but you also listen to your community partners and engage them to build on community capacity to make that change. Because really the health equity that we see in our region is really, it's not just healthcare disparities, it's disparities in all sorts of different outcomes, whether it's employment or education or housing or just our communities in general. So we need to think about our, the first step to really making an impact in health equity is to really take a step back and think about what resources are here and what we need to support.
Great point. Hope?
So I agree with exactly what you said, Sarah. I really think about the health equity very simply. It's what do we need to do so that everyone has the same opportunity to be healthy. We often see this picture at conferences that'll show 3 people trying to look at a game. And often they'll have the people trying to look over this fence and one person's short and the next one's a little bit taller, and then the tallest person can see over the game. And that framework really is not about equity, because if we're really talking about equity, though, it's 3 people that are the same height, but on a hillside. And one person can see over the fence and the others can't, because the system has been created that doesn't allow everyone access to the same view. And so we really are looking at what can we do to change that system. And I was thinking about that as we were getting ready to meet today, Eric, and I was remembered on 75th and Metcalf, CVS and Walgreens are right across the street from each other. And you can go all over Johnson County and find CVS and Walgreens right across the street from each other. Then go into neighborhoods in other parts of our city, in our Kansas City metro area, and it's a pharmacy desert. And here's people trying to get medicines for their treatment, and maybe they might not even have a car, and maybe the pharmacy isn't even on a bus line. So that's an example of how the system in our city can be really different. And so for the Masonic Cancer Alliance, we're really focused in on how do we get programs and services to where people are at, and how do we do that in a way that the community wants us, and how do we partner with the community, and they're the ones that will tell us how we can be effective. And I'll tell you more about that later.
Thank you so much, Hope. That is an incredible point, and something I want to dive in later about the system for all of us to have a discussion about what that is, and how we can address it. Natty, same question.
Love what Sarah said about centering community voice. Obviously was excited, Hope, when you talked about system, because I immediately think when we talk about equity, we have to hand in hand talk about those systems that prevent equity from happening. And when I talk about the systems, let's name them. Structural racism, which is that system where our public policies, our institutional practices, our cultural representations, and the other norms with which we work and live, and all of those things perpetuate racial inequities, which then leads to structural violence. So that's what, the systemic ways and the societal harms that disadvantage individuals who are, at a certain point in the hierarchies of politics, social, economic, etc. And then that causes them to be structurally vulnerable. And the thing about structural vulnerability is for us to remember, and this is why I like the community piece so much and the policies piece so much, is that it's not about the individual and it's not about individual behavior. So it can't be repaired by the individual. It has to be repaired at the system level in order for any kind of equity to be achieved.
Amen. Absolutely. Crystal.
Wow, mic drop. I don't know what else was
Yeah.
but I tell you. But what I will say, health equity, just like some of the stats that you mentioned, Erica, me as a health communication scholar, I will say that so many people in different, all walks of life, like back to what you said, there's just, as far as communication, even though individuals are receiving, information about cancer, we are processing that information in different ways. What if my literacy level is not the same? Or what if, my doctor that is giving me this type of information, there is a gap culturally. There's so many different things that is to consider just with communication inequities. And so I'll just draw from one of my experiences recently as a health communication scholar and conducting cancer-related genetic counseling, testing and communication. That's something when I asked about this whole area, this topic, one of the individuals in a focus group said, wait just a minute, I haven't even heard about something like that, and so that wasn't a point that, with data collection, we were going to explain that, but it kind of went into another direction where these individuals were saying, okay, it goes back to the system. Here we go yet again, where this could be a life-changing tool for my cancer prevention that I know nothing about. Why is that? Why have I not been informed about this? And so with equity, I would say, just piggybacking off what everyone has said, it is having those equal rights, freedoms, and privileges to receive access, to receive information, all of that. And absolutely, it is ecological. It's from the system, from the individual to the system level.
Mm-hmm. So we'll dive in more into the concept of the system, because that happens to be, as we were talking even before we launched into this recording, the political determinants of health, which has created the structural system that we're currently reacting to, is something we have to have a strong will to correct. And there's a lot of easy solutions that are good first steps in creating a public policy space that actually makes a difference. And, I'll put the call to action later at the very end of this, because we are approaching, the biggest election of our lifetime. And we're asking voters to vote as if your life depends on it, because as you will hear today, it 100% does for every single one of us in our communities. So before I get too passionate about the call to action, I'll go to the second question. Sarah, kicking it off with you again. What are some of the strategies in each of your, broadly speaking, each of your professions have you done to work towards equity for the health of the community that you are serving? So for everybody, Siteman Cancer Center is on the east side of the state for Missouri in St. Louis.
Yes, so as part of our PCAD group, we have really focused on building strong community partnerships to help us with better understanding the needs within the community and what sort of education we can provide. But then we've also started to take a look sort of internally and trying to make sure that the environment here within Siteman is also reflective of our community. We're trying to encourage sort of diversity of opinions and also more research that's geared towards understanding and appreciating a diverse population. So we really want to make sure that the research that we're conducting is responsive to our population and is addressing those established disparities. So as part of what we do, we monitor our clinical trials accruals. We try to ensure that our clinical trials are designed to target issues that disproportionately affect certain populations, and that we also are encouraging researchers to branch out into new areas of research and to really understand what diversity means for their projects and to understand how important it is to have a diverse cohort within your projects. It's all fine and good from a research perspective if we're pushing out these new treatments and new medications and new theories, but if we're not reaching everyone equitably, first off, there's the whole moral issue associated with that. But second, your data is flawed before you even get going. Mm-hmm. So we're really sort of like pushing this equity in terms of that research and equity need to go hand in hand, that we can be the bridge, but we need to look internally and make sure that we're fostering that type of environment here.
That's incredible. And I'm going to go off script for a second. So AACR, the American Association for Cancer Research, released their Cancer Disparities Progress Report 2020. I have it sitting on my desk here. I've made it through about halfway. The notion of precision medicine becoming so prominent in care and treatment, I'm wondering what the balance will be in kind of the evolution to the point you're making, Sarah, as research becomes, it becomes more important to have those diverse populations to be able to respond to the appropriate treatment for the best health outcomes. I mean, what do you think?
I really think a big part of it is us understanding where these disparities are located, and then sort of looking at it from both a social perspective as well as the biological. I'm a bench scientist, so I see everything as like data and numbers, but I partner with social workers and community health workers and all of these other team members to include people from all different backgrounds so that we're all thinking about the same problem from slightly different perspectives, but with the same end goal in mind. And I think that's really where we're going to start to make some forward progress, is that you have to bring in people with different levels of expertise and have everybody on equal levels within those conversations. You know, engaging community members is just as important as engaging the physicians and the researchers and the social workers and the politicians. We all need to be at the table.
Absolutely. Hope.
That's a great segue, Sarah, to what I'm going to talk about. So thank you. So the Masonic Cancer Alliance and KU Cancer Center just launched an initiative probably 2 years ago called Pivot, Patient Investigator Voices Organizing Together. And our goal was really to provide the toolkit for both patient survivors and co-survivors, as well as researchers and partnering on research. Because we don't know, when you're sitting in the academic medical center trying to create science, we don't know what we don't know. We don't know what's important to patients. We don't know what is causing problems with enrollment onto a study. We just don't know. And we have experts sitting right beside us in the community who really have a lived experience in cancer. And so we've started a project to really, and now we have over 100 patient partners who are willing to partner with researchers to really expand the research in a meaningful way. So that's one area we're working on. We also can't expect everybody just to come to us to participate in clinical trials. You really have to open studies where the patients are at. If you want to have a diverse population, participating, whether it's from someone in a rural community or someone that is in a metropolitan area, whether it's an elderly person or a child, you have to open up the studies where they're getting care, because that's their trusted physician. And so MCA has opened up in partnership with Truman and Children's and in Salina clinical trials, so that people are able to participate in clinical trials with where they get care. And we think that's super important. And then once you have that science and knowledge, working with our community advisory board to really push that into either the healthcare provider's hands so that they have the most up-to-date information, or in projects in collaboration with partners such as cancer screenings in the community. But that partnership, just like you talked about, Sarah, with the healthcare providers, the scientists, and the community.
Amazing. I see actually some Pivot members are on today's call. So thank you for participating. Natty, same question.
So I think Hope, Crystal, and I saw Jill Peltzer in the audience, who's my colleague, has sort of heard me talk about this ad nauseum. But I like to be able to frame the work that I do in education, community engagement, and research through this framework called the Equity, Empowerment, and Social Accountability Framework that was sort of developed by Williams and Wyatt. And it's a trauma-informed contextual framework that recognizes history, that promotes collective input, so everybody's voice matter, promotes shared language, because I think that's one of the key things as we work through all those three areas, and also works to promote this idea of self-assertion, meaning that confidence that you are valued as a person, as a community, and that you are able to talk about what's important to you, and that you're seen as a whole rather than a disease, right? And then this framework also inherently believes that inequities are avoidable, and inequities exist because of entrenched colonizing mechanisms. And we need to start sort of decolonizing ourselves if we're really going to get to those questions of equity. So through education, I do this through how I teach medical students. I am in our curriculum, I'm the thread head, or the person who creates the learning goals for the social determinants of health. So I get to think about this a lot in terms of the education experiences I provide for our students. So there's a lot of anti-racism and implicit bias work that I do with students that I also do with faculty, because the people who teach our students need to be on point as well. In regards to community engagement, I think about it as how we centering the community in all our conversations. As researchers, as academicians, I know it's so hard to do that. Our agendas always seem to creep into those conversations. How do we look at our communities from a strengths-based perspective rather than from a place of lack? Because that's not empowering at all. How do we address power relations, right? And then in research, making sure that we're asking questions that are relevant to our community. Like we talked about multidisciplinary approach, a strengths-based approach. But the final thing that I am really working on with my research is questioning the ways of we know things. Who do we value as the expert? Whose voices are we valuing? How may we be causing harm unknowingly in our communities that we're trying to help? Because we really need to think about whose knowledge we're prioritizing, because we might just be, continuing this harm by the very structures that are causing the inequities amongst especially minoritized groups in this society.
Because they've been ingrained for so long, right?
Exactly. It's ingrained for so long, we can't even see it. And so that's why I love conversations like this, because they may not be easy conversations, they may be uncomfortable conversations, but that's how we start deconstructing the very systems that are reifying racism, that are reifying inequities, and continue to cause poor health outcomes for minoritized folk.
Absolutely. Crystal.
Powerful. I said, yes, me and Natty and Hope, we work so much together. We have this symbiotic relationship. I said, Oh, Natty, I second that. Underscore
Exactly.
that. But what I will say that just in my process, back to the beginning when you asked us to introduce ourselves, I am a CBPR researcher, community-based participatory researcher. And I have to say, as an African-American, as you can see visually, I'm African-American, I will never forget when, I started my journey to do this community-based participatory research. And so I approached, a body of people, faith, population, African Americans. And after my conversation with them, I remember them saying, so what? They didn't say it quite like that, but why should we trust you? And it really gripped me. I was wondering, hey, I'm from the community. I was born in Missouri, raised in Missouri, born in Missouri, and now work in Kansas. And so it just made me, do some introspection, and I just could not understand why. But it's, again, going back to what Natty said, a lot of these things, systemic racism, these individuals had experienced time and time again. Even though we come in, there's a group that I have had conversations with in the faith populations. I'm not sure if you've heard of, there's a documentary that's called White Savior. And so a lot of these individuals have, talked about this, even though I'm not white, it's, this kind of mentality or thought that because of the research that I have conducted, and that is basically aligned with other researchers that have come into, that community at that time, that they want to save us from this. Maybe we don't need, they didn't say we don't need saving, but it's just coming from a perspective, including the community in that process. So critical. And another thing that I will say is that many of us that say, oh, we do community engaged research, we do CBPR. do we really do that? Because again, we're coming from our perspective. And it's not to be a tokenism. It is complex, but it's so important that those unusual voices are infused into the process. Otherwise, we're going to keep continuing to come up with this or just face these same issues time and time again. So it has to be authentic. Like, back to what was said, it is uncomfortable, but making the uncomfortable somewhat comfortable, that's necessary.
Absolutely. Absolutely. You reiterated the point we talked about before we started the discussion of the hamster wheel, which I think as advocates or, and as just passionate human beings, we want to see action and we want to see some solutions in a more equitable society as, community members, as parents, as just individuals. How do we take action? So that's actually kind of a good segue to my next question, and I'll go back to you again, Sarah. With everything we've experienced since the national declaration of COVID back in March, and seeing what what the world has gone through, and seeing what certain populations are bearing the brunt of this disease and the outcomes, and the injustices that we are seeing, and I'm not thankful for the experience, but I'm thankful for the awakening, because we can finally, hopefully, actually address this. So from your perspective and in your region and your professional experience, how do we harness this moment really to move forward? I know that's a very big philosophical question, but
yeah.
How do we do it?
Well, a lot of it, I think, is building on momentum. It almost feels like everyone just sort of realized what public health has been doing this whole time, and they're actually starting to realize that we're here. So I think it's a good time to have the difficult conversations, because we are in a place where we need to give our students and our faculty and our staff and our community members permission to ask questions and to learn and to grow. We need to sort of take the opportunity that's been given to us in this. So a lot of what we're trying to sort of move through is understanding a lot of the same inequities that we're seeing in terms of the COVID distributions within our community are identical to what we've been fighting in cancer. So it just makes sense to build on our existing resources and knowledge and capacity to be able to bring the resources where we know that they're going to need to be. So we've been part of the COVID and cancer different research groups, trying to really understand not only how COVID is impacting our community, but also how it's impacting the cancer care continuum. Because our main concern is for our patients. We don't want this to undo any of the progress that we've made. We have been making incremental progress through a lot of hard work and boots on the ground and sincere partnerships with our community partners. And the last thing we want to see right now is that COVID sort of scares people away from seeking healthcare. You know, we want to make sure that they realize that cancer didn't stop in the wake of COVID, and that we as the providers are here to help them navigate sort of the situation and to be open and honest and give them the information they need to make the right decisions. So I think it's a lot of just like, we need to keep building on this momentum. We need to take the opportunity that's been given to us and sort of make lemonade out of lemons with the year that is 2020, and sort of start to have these conversations in a real way.
Absolutely. And what you mentioned, I just want to give a quick reminder to everybody here. If you are 40 and above, please schedule your screening mammogram right now, because COVID is telling us the data coming in, and everyone knows that screening rates are down. And so just a quick reminder, if you haven't done that yet, please go ahead and do that. Hope, same question. How do we harness this moment and not miss this opportunity to create some progress?
Well, I think it's part of what we've been talking about all along, being present, showing up, staying there for the long haul. Because if we're just here during this moment and walk away, we've just ruined, we've like dropped off, and that's not going to make it better. And so we're doing a few things. I mean, we're looking at ourselves at the Cancer Center and going, do we reflect the population in Kansas City, or do we know, or the people that work here, do we look and come from the same communities as those we serve? And often the answer is no. And when the answer is no, then what are we doing about it, right? And so really looking at hiring practices, really thinking about how are we making sure that those that work at the Cancer Center, whether it's educating people across the site into medical professions, or as a clinical research coordinator, where are we advertising, all those things. So really taking the hard look. Having those conversations with partners for the long haul, that when you're there long enough, they can tell you when you have messed up. And I can tell you, I have messed up. but if you're in those relationships with people and you're not just showing up for a day, then they're going to, as a partner, say, you might think about saying that a little differently, or you might try working here. And that's really important. And you have to be ready to hear that. You also have to be ready to give up some leadership, right? If there's no space for others to lead, then that creates problems too. And so if you listen to the KU Health System's Facebook Live this morning, you will hear, so go on to Facebook on the KU Health System, you'll hear Broderick Crawford with Mario Castro and Alan Greiner. And Broderick is a community voice who's been doing amazing work in health equity, a community partner who's a co-PI on a COVID study. And that's the way we make change. And then finally, we think about some of the structural things, like Missouri's getting Medicaid expansion. It should start in July.
Finally.
If people are diagnosed with cancer and they don't have insurance, they're 50% more likely to die. Medicaid expansion is going to make a huge difference for that state. So we're so excited. Kansas does not yet have Medicaid expansion, by the way.
Yeah, we got a lot of work to do there. I love your point about being ready to step aside if as a leader, if it doesn't necessarily make sense and if it actually doesn't benefit the community or what the objective. That's a really important and very thoughtful point that I haven't, quite frankly, thought a lot about, and it's absolutely right. And I love seeing that Broderick, whom we all love and know, is a co-PI on a project. That's incredible and a great signal to the community, right? Absolutely. And plus Broderick is amazing. So
We all love them.
we all love him. Natty.
I love, Hope, what you talked about, because basically what you're saying is, are we being accountable? And I think that a lot of us have sort of focused on, diversity initiatives and things like that. But at the end of the day, are we engaging in tokenism? Are we not actually doing the inclusion part and the justice part of the diversity? And, a lot of our organizations are socially responsible. We're aware that we have to do good,
Right.
and we try as much as possible to do good. Some of us are socially responsible. We implement things to make sure that we're helping our communities, and these things are data-driven, etc. But it's still very top-down. I think accountability is so much harder. Accountability asks you, like Hope said, to put aside your ego and step aside. Again, I'm going to say that's hard for academicians. Accountability asks us to seriously interrogate our systems, our processes, our curricula, all of these things, our hiring practices, how we deal with our patients, our inclusion of patient voice, who's defining the agenda. All this whole list of things sits in the accountability box, and that is really difficult. And I have found at all levels of organizations, and all levels of society, it's really hard to get to that piece. Because it's asking for people to be introspective and also action-oriented in ways that our society doesn't necessarily support.
Mm-hmm. Absolutely. From a public policy perspective
Right.
to everything. Absolutely.
Right.
Absolutely.
Mm-hmm.
Again, I just agree with all of my colleagues. But what I will say also, as we're talking about just our processes, as Natty said, and doing introspection, I would just also say, and then like Hope, what you said, stepping aside, leadership, letting others lead when it's uncomfortable, because we are so used to leading in the way that we want to. But I would, also say with, looking at and acknowledging what is happening, acknowledging our own biases. I mean, Natty, you talk about that you've well done with training implicit biases and recognizing that we do have these biases and being true and having authentic conversations and starting there and with that acknowledgement, accountability. And then I would also say, we have our mission statements, right? Really looking at those mission statements. I know that sometimes those mission statements are just maybe, they're on the wall, they're printed out, but really having diversity, equity, inclusion embedded into our mission and filtering out from there and doing, having that in a part of our processes in everything that we do. So just cannot agree more than enough with the panelists as well, though.
Can I add something to what Crystal said? Because it just reminded me that acknowledging also means acknowledging, confronting historical, which is now turned into contemporary spiritual suffering.
Yes.
The suffering that minoritized groups continue to face from the past into the present. Yeah. And we have a thing where we brush it under the carpet. We say, well, that was 300 years ago. That's not an issue anymore. Or that's not manifesting in ways that make sense to me. So it doesn't exist. There's a lot of denial that's going about. And I tell you, that denial sucks it out of you. Folks of color carry that denial in their bodies and in their spirits as they move through the day. And I think that's what this year has shown me, that we cannot ignore any of that. It is relevant. It was horrible then. It is relevant today. And it is actually impacting the health of our minoritized communities in this country. And if we don't talk about it like concretely, we're not going to change anything.
To the point that it's actually genetically imposed
right.
now. I mean,
yes.
One of the conferences that I sat in on listened that there's been genetic linkage between Jim Crow laws, segregation in the South, to a higher disposition in African-American women being diagnosed with triple negative breast cancer. That is a powerful statistic. That is literally in the genetics now because of that experience and that suffrage and that horrible time during our country, that is now genetically influencing a person's genetic makeup. That, I mean, I think I sat back with my mouth dropped just thinking about that.
And Erica, I will say too that, you know, as a researcher, I know that we're probably getting off script here, but it makes me think about just, especially with African-American women being slightly less likely to the incidence, but more likely to die from it. But even when you have factors such as economics or the education and income, women across the board still are dying disproportionately. So what is it? And so that is what Natty said, what you said, that some of those factors that we have not even considered, we haven't even thought about.
No, not at all.
And I would add to that, just if you look at the mortality rate just by zip code in Kansas City Metro, there can be a 20 years difference. Well, why is that? What is that difference? What created that? Well, let's look at our housing covenants. What created where we live? That's not healthcare, but it completely impacts our health. And so we really have to start looking at that. That's what those are the same neighborhoods that don't have the pharmacies. That, you know, it's so interconnected. And what I'm loving about what Natty is saying is naming it. If we're seeing racism, we need to name it. We need to figure out then how to address it. We can't just go, oh, no, I didn't mean that. No, let's just name it and work through it and fix it.
Right. And we need to stop using race as a proxy for genetics. We need to talk about not race, but racism that's causing the disparity. And even though race is an influential construct, it's made up. It's not real. So let's really talk about what's the real issue here, right?
Mm-hmm. Absolutely. This is, again, I feel like I could talk to you all for hours and hours because I just get more energized and excited to know that there are, I feel very lucky to live in a community with all of you, a part of it, both Kansas and Missouri, and getting to collaborate on these discussions. And I know this is one of many that will continue, regardless of where we are in the future, what happens, how the election turns out. I feel like by us being a part of this today, we are committed. We are on the record committed to doing this. So, I will flow into the next question, which kind of talks about, or that I posed to you all. So diving into the breast community, we know Black women are more likely to die from breast cancer than any other race. We see specific areas of our state in Kansas and Missouri that are experiencing above national average mortality rates. And we kind of addressed some of those reasons here by, from housing to how our cities were constructed to where, businesses are located, so on and so forth. But Kansas and Missouri geographically are somewhat similar, meaning we've got some, urban populations around the larger cities, but then we have very rural dispersed population. And I think even under the notion of health equity for our region, the rural aspect is also a piece that will have to be addressed. And Sarah, I'll start with you. If you've thought about this, or if you all have incorporated looking at some of that at Siteman as well.
Yes, definitely. We have been looking at sort of where are our patients coming from? And so by looking at and knowing what % of our population is coming from urban areas and medically underserved areas versus rural areas, it really gives you a better sense of maybe some of the barriers that the patients are going to face to completing treatment, to getting on-time screening. Just understanding the geography will give you a lot better insights into who the patients are. But you also have to know that the culture in a rural community is going to be much, much different than in an urban community. Mm-hmm. So if you're coming as someone who lived and grew up in a city and trying to sort of all of a sudden move into a rural community and expect to be heard and to be sort of understood, there's a disconnect. So we've really been working, we have a community research fellows training that we've been doing in the St. Louis metropolitan region. to help us sort of build community capacity and sort of help train our community members about sort of what we do as researchers, what is our job, and sort of here's what we're doing, and sort of clue them in on the whole process. And we've been, some of my colleagues at PCAT have been working on adapting that same program to rural Illinois communities. So we just graduated our first cohort of the Rural Education for Advancing Community Health, or REACH, which is sort of has that rural focus. And it was really interesting to see how many things that were transferable, but how many things you had to slightly adapt or just completely rethink as you're developing the same curriculum, but targeting it to the different audiences. So I do think it helps to have partners who are already members of these rural communities who can help you with sort of better understanding the unique challenges that you're going to face. Even things as simple as internet access. You know, they can't do Zooms. And so if you're trying to reach them now in this digital world, how are we going to be, if we can't be boots on the ground and we can't rely on internet, what are our options? So you do have to get a lot more creative and a lot more sort of like thinking about it from a variety of perspectives, but understanding the community that you're going into is going to be a key part of that. And just knowing that it's not a one size fits all approach. Like you can't, even if just saying Missouri, there's so much differences between county to county and even neighborhood to neighborhood. Like there's a lot of unique little niches within our region that we really need to sort of appreciate and try to work with.
Absolutely. Hope.
So I often think about how we partner with our rural communities. One, we have pivot members that are from across the state of Kansas, as well as community advisory board members from across the state of Kansas. But I'd like to focus right now on our cancer centers that are located across the state of Kansas. And even though there might be a cancer center in Hayes, people are still driving 2 hours to get to Hayes in order to get care. So we first have to think about that and just all the dilemmas around getting a screening or getting care. And maybe they have jobs like farming, where there's a farming season where really going in is really kind of challenging. But also, let's think about where the drugs are often developed, which is academic medical centers. And one of my first aha moments, I think, working at the MCA was we were trying to move an investigator-initiated trial, something that was created at University of Kansas, a drug study, and move it into an MCA member location in the rural community so that they could test it to see if it works as in the way that they thought it would work. Well, immediately the physician said to us across the MCA, you know, this drug is set, so you have to give the drug 7 days in a row. That's just the way the scientists developed it, right? Mm-hmm. That's how they decided to give it. Well, that's fine in Kansas City. You know, we're open 7 days a week at the cancer center because that's how we, you know, the number of people we see, right? That can happen. In a rural community or in any community cancer center, that could be a real challenge. 85% of people with cancer are treated at a community cancer center. So all of a sudden, we're creating studying a drug in a way that only 15% of the people would be able to get it in the way that it was studied. And so by including those local physicians at community cancer centers as we're creating the study design, they're able to then really have input in and saying, you know, that's not going to work for most of us. And so that's one of the ways for rural communities we're trying to address disparities, is really looking at how care is given locally so that the study is designed in a way that meets the way that care is given locally.
Fantastic. Natty, what are your thoughts?
And Hope, that means it goes back to what Sarah said, is that you had to talk to the people, right?
It's
all the time.
Questions in the first place. And it just, you know, it just seems so elementary and simple that we need to listen and shut up. But obviously we haven't been doing it very well. Yeah. So I think then that it also goes back on us having to do a better job of learning to listen. Like, let's go back to nursery school here and learn again how to listen. That's just an aside point. But also, Erica, I remember I think in our previous discussion, we talked about how sometimes we're able to hotspot communities that are really specifically challenged by breast cancer or other kinds of cancers, and really sort of doing some deep dives and deep listens with those particular communities. Because what is it that's so unique and so different about where you are and where you're geographically placed that's causing for some of these things to continue to happen in your communities? Yeah. So I think I really agree with adapting strategies, with listening to communities. But if there are ways, and from a communication perspective, you can target, like really sort of hone in, like bullseye, some specific groups, and then work with those groups, do all the listening, the engagement, all that good stuff. That could be another way, I think, that we could start to address some of these mortality rates. That's
absolutely.
Yeah,
absolutely. I couldn't agree more.
And that's where a lot of our team comes in. Like, we're there to provide the data, because it's really hard to know where to start if you don't really, if you haven't really defined the problem and you don't really understand the unique. But we're thinking about data a lot differently. It's not just incidence mortality done. We're now trying to pull in data about transportation access and housing units and financial toxicity of cancer care. All of these things that really were sort of like periphery, we now realize are part of the problem, and we really need to be tracking all of these issues. So we've really been rethinking, like, what do we define as data? It's not just numbers and medical data. It's a lot of the social determinants that wind up being the really important, crucial demographics and numbers that we wind up using to inform our outreach strategies.
And then Sarah, how do you tell the story to our funders that actually you're interested in this here, but let's tell you, like, it's this stuff here that's really important. Fund us to address this stuff here, and we'll get to this. A lot of funders find it very hard to get that.
And we've actually started implementing, we pull together these dashboards that we're circulating within our research community. So anyone who's doing some of these grants, we basically provide them all the information about, here's our population, here are the challenges they face, here are the smoking rates in these communities, here are the rates of obesity, here are the rates of all of these different sort of social determinants, and we include that and continue to circulate that message within our research community so that they're thinking about it, and at least they're sort of now acknowledging that this plays a key role in how their research is going to be conducted. And also the patients that they're seeing are not like lab rats. They're not in a controlled environment. They're out in the real world. We have to know what that real world looks like to fully appreciate the challenges that we're up against in providing the best care for them.
Love that. That's great. I love that.
Crystal.
Educate.
Oh, I said, oh my goodness, Sarah must have been, and Natty, my thought process there, but but absolutely, engaging those communities is so important, that those trusted individuals are part of that conversation. And then the other thing that I had a thought and I forgot, but it's just important engaging those persons in the process, having those authentic conversations. And that's what I was going to say too, from a communications perspective, as far as tools, also, and I think we've already mentioned this about empowerment too, having those individuals empowered. Like one of the things, my research, just working with pastors, for instance, this is maybe unconventional, but looking at some of those issues that are within the community and taking that to media advocacy, and bringing that to the forefront. But definitely it's important to engage those community members in the process. So.
Absolutely. So we have 6 minutes left. So if there are questions, please pose those in the chats. Let me see here. It looks like okay, so here's a question by Carol Bush. How do the dashboard notion is an incredible concept that sounds like could be expanded upon. How do we do this for our region?
we do have access to some of the different infrastructure is there. And I'm finding that there are a lot of resources out there if you know where to look.
Yes.
So even things like 211, as a data person, I seek out all sorts of information. And I was completely oblivious to the like great data that I can get from that resource. So a lot of it's just sort of thinking differently about where your data sources are, and also enlisting our community partners to help provide us some data, because they may have more detailed numbers about specific neighborhoods and needs within neighborhoods. If they can tell you like what % of their clientele are needed bus pass to be able to get to resources. We're even looking at, we've implemented some transportation assistance programs through Barnes and Siteman. So looking at our Lyft data to try to figure out who's using this. Are there certain neighborhoods where we know that there's a high % of the population that doesn't have a car? And are those the same neighborhoods that are taking advantage of Lyft? Because if they're not, then we know that there are certain neighborhoods who are not getting the message that this is a service that we can provide. So we're taking a different look at how we're using the data and how to be the most impactful with what is available. Because there are some things like mammography rates and HPV vaccination rates, things like that, that are delayed when you rely just solely on national data. You know, you're always working like maybe 4 years behind. But if we can think about it more creatively and sort of like build a community that's willing to share information in a HIPAA friendly way, but to be able to share information about our community, that might be the best first step, is really to sort of really understand what's going on at a neighborhood level.
And you know, Sarah, that made me actually think about something I was going to bring up earlier about resource asset mapping, essentially. Identifying, you know, having in a visual way, mapping where those assets are. And so that is something, a tool that you can see at a glance, okay, these are the assets I have within the community. So that's something I forgot about.
And you can only do that with the community, right?
You can only do that with it. That's right.
Yeah, that's come up in a couple of the different work groups at Missouri Cancer Consortium over and over again, is that somebody will mention some resource and we're all like, we're engaged in this research. We're really passionate about these. How did we not know this? And so for us to not be aware of some of these resources, we know that we need to find a better sort of like way to network some of these different great community, like build on existing capacity. If there are groups out there who are already have the resources and the networks and all of these systems in place, let's build off of that. Let's support them and find out what we can do to further their mission.
Sure. And I think we're doing some of the similar work at KU Cancer Center. We have a catchment committee, which is really a fancy word for our service area. And we have community members as well as scientists, as well as clinicians on that committee. And we're layering data from a lot of sources, some publicly available, like the County Health Rankings website, and some that are only available inside the walls, so to speak, like who we serve. And the addition of the community voice really helps you narrow it down. But in the end, if we don't connect that data, as Natty and Crystal and Sarah have all said, back to the community, and the community helps us understand what it means, and the community helps us understand what is needed to make a difference, it still will just be data. And that's why I think you've heard all of us talk about the importance of taking kind of that micro-targeting in partnership, you know?
Yeah.
In partnership.
And also we're not always involved. Right. And our priorities, the hardest part I think we find is that our priorities are not always the priorities of the community. And if we're asking something of the community, we need to be willing to get back to the community around what their priorities are too.
Oh my goodness. So I know that we're running out of time, but Hope, I wanted to underscore that, because sometimes it may not be about the health issues. Maybe it's something else. I mean, in the work that I do, it's not uncommon that I'm attending a Bible study. I'm going to a basketball game. It is reciprocating, have that mutual respect, that relationship. So I just wanted to throw that in.
Yeah.
So I think today we have gotten off the hamster wheel, which is a good thing. We started the conversation saying the thing that I think most people who are passionate about health equity feel is frustrated is that we are on a constant hamster wheel of discussing the topic and discussing it, but not moving forward in a real way. And I think today there were several themes that were kind of brought out. One, we very much know the data shows, and all of you underscored, where you live is a better indicator of your health outcomes than anything else, any other factor. And that first and foremost, I think really is an important data point to acknowledge with everything that we do and every effort we work on as it relates to health equity. Secondly, speaking, the needs and the challenges and the barriers we were discussing are underscored by what begins and ends with health equity, which is the political determinants of health. And fortunately speaking, this is now my passion as it relates to how do we move forward specifically on health equity. We've got to still understand the policies that are in place that have been the instigator to these social determinants of health, of housing, of the highway structure, of the way neighborhoods are coordinated, of laws that have been passed that have now systematically changed the genetic DNA of a person. We appreciate that and understand, and perhaps need to start there from a health perspective as well. I just want to thank you all for such a great, honest, and uplifting conversation. It feels good to be networked with some really strong, powerful women who are working to make positive change in our communities. And I have full faith we're going to do that in Kansas and Missouri. I want to end with just a final call to action for everybody. I want to give you some dates. So what can you do if you're listening to achieve health equity? First and foremost, vote. Again, from a public policy perspective, as you heard today, that is one positive step you can take towards achieving health equity. Missouri, today is the last day to register to vote. You can, if you are registered to vote, you can vote absentee in person now. So I encourage you to do that. Kansas, October 13th is the last day to register to vote. In Kansas, you can start voting in person on October 14th, and election day is November 3rd. So please, if you do nothing else, vote. Thank you again for participating. And this is the first of many conversations. I ask everybody on this to hold us accountable, as we talked about, accountability. This isn't the end of this discussion. So I'm looking forward to moving forward, and thank you all for participating today.
So
all right.
Thank you.
This was fun.
Wow. Oh my goodness. Wonderful.
Yeah.
Thank you so much, Erica, for having this and for your heart. And then, just what you're doing. I really appreciate it. And all of you too. I tell you, I am being very honest when I say what I'm about to say. I was so excited. I couldn't wait. I was thinking about this all week. I had talked to Natty last week. And and it's great to meet you, Sarah.
Yeah, you too.
Hope you know of what my just admiration for what you do every day. And so, but all of you, thank you for what you do too. And so you inspire me to keep going. So,
For sure.
Thank you. No, the thanks is to all of you. You all are doing the incredible, incredible work. I'm just here to facilitate the conversation and step aside from a leadership perspective because I know that's important. But quite frankly, we just have to have these conversations and start moving forward. And I'm all about results. And so I want to find some results and a way to achieve the end goal. And from our perspective, from Macomb, I want to end breast cancer forever. And as I mentioned to you all before, that begins and ends with health equity. So thank you.